Thank you very much for the introduction, and Assalamu alaikum. Good afternoon, Medina. It's truly an honor and privilege to be here as we close this remarkable conference with the last session of the day. My dear colleague, Dr. Yamani, and I will be exploring with you the fascinating world of HHV8 and EBV, the most oncogenic viruses known to mankind. This topic is very near and dear to me. I dedicate it to one of my patients who I saw in the very early stages of my career, and I got to follow her disease evolution till the end. So as we begin, who recognizes these two gentlemen? You can shout out the names if you do. Anybody? Well, yes. So you probably know that the Epstein-Barr virus was named after Sir Anthony Epstein when he discovered the virus particles in the Burkitt lymphoma. However, have you ever wondered who is the Barr in the Epstein-Barr virus? Well, as legend has it that Dennis Burkitt was a British military surgeon, and he was posted in Uganda. During his post in Uganda, he encountered Ugandan children with massively swollen jaws, a condition that will later on be called Burkitt lymphoma. He presented his findings in a conference in London, which would be attended by Sir Anthony Epstein by pure serendipity. Epstein's curiosity was piqued when, with the geographic specificity of the disease, and he proposed that this might be due to a virus that is transmitted through mosquitoes. This set a stage for a collaboration where Dennis Burkitt will send biopsy specimens and send it all the way to Epstein's lab in London. So in London, now Epstein hired a research assistant who is an Irish scientist with a background in zoology. This research assistant was successful in cultivating tumor cells in cell cultures. And according to Epstein's notes that in a snowy day in February 1964, he was able to identify virus particles using an electron microscope that Barr had cultured. The Barr belongs to Yvonne Barr, the research assistant who retired as a school teacher after leaving the medical field due to gender discrimination. But she left behind her a legacy that is immortal, just as immortal her immortal cultured lymphoblasts. So why is EBV important, and why should we care? EBV is one of the most growth-transforming and the most widely distributed human pathogen in the world. 95% of us will be infected by it, and 95% of your patients will be infected by it. So to make the best of our session today, we are going to discuss these disease entities with the main goal being, I'll give you a background of virology of the EBV. Now that we have the schism in the classification of the WHO 5th edition and the ICC, we'll touch on the main updates and giving you some highlights in the biological insights to show you what are the new trends and where are we really heading. So the EBV belongs to a group of gamma herpes virus 4. It was one of the first viruses to be identified by the WHO to cause cancer, and is considered as class 1 carcinogen. Most of the people infected by the virus will be asymptomatic and will be hosts or carriers for the virus for life. Depending on the time of infection, the severity of the reaction, the patient might develop a self-limited bout of infectious mononucleosis. The virus particle itself is a spherical particle with an envelope and glycoproteins on the surface. The nuclear genome is a double-stranded DNA enclosed in a nuclear capsid. When these viruses virus attacks the B cell, it attaches to the B cell and incorporates the DNA within the nucleus in circular forms. It expresses certain surface glycoproteins and certain nuclear proteins. The surface proteins being LMP1, which activates the NF-kappa B signaling pathway, and LMP2, which is an analog for B cell receptors. The EBV infection can be divided into three main stages: the primary infection or the lytic replication, the latency phase, and the lytic reactivation. So the virus will enter through the saliva, it's transmitted through the saliva, crosses the mucous membrane, and attaches to the B cell. It will activate an EBNA2 derived B cell replication. Now the naive B cells will enter a latency 3 pattern infection. Here it will express all the EBV gene expressions. From there on, it will move on to differentiate into the germinal center B cells, where now it will enter a latency 2 pattern infection. It loses some of the gene expressions. From there, it will go to the forming memory B cells, which is the latency 0 or the latency 1. And here, this is considered as the resting phase of the EBV. This is where it will stay dormant. From latency 0, now it will go into the circulation as memory B cells, and it can go into lytic reactivation when it transforms into plasma cells. Now, all this is controlled with an intact cytotoxic T cell response. And if you consider the latency 3 as the storm, latency 0, I consider it as the calm before the storm. This is what gives the pathogenicity. This is what gives the cunningness of the virus, because it goes into the host dormant, undercover, hijack the immune system, and it waits for the right time when there is a breach in the immune system where it will take the opportunity and start proliferating without control. Let's look at the latency phases closer. So as we said, there are three main latency patterns: latency 3, latency 3, 2, 0, and 1, and they differ with the gene expressions. Latency 3, as we said, expresses all genes. Latency 2 start losing some of the genes, and latency 0 will express only EBR. What gives the oncogenicity of the EBV virus? When the virus particles attach to B cells, they activate signaling pathways, in particular NF-kappa B pathways, JAK-STAT pathways, which are similar to any oncogenic cell stimulating signaling pathways which produce or enhance replication and decrease apoptosis. Also, the EBV stimulates cytokine release such as CXCL10, CXCL19, which gives the milieu of where the virus rests. Now, certain lymphoproliferative disorders that are associated with EBV are correlated with latency patterns. So, for example, Burkitt lymphoma, plasmablastic lymphoma are strongly correlated with latency 1, where only EBR is expressed. Let's take classical Hodgkin lymphoma. It is strongly correlated with latency 2, where LMP1 in addition to EBR is expressed. And last, let's say an immune deficiency related infectious mononucleosis like reaction or a PTLD is associated with a latency 3, where LMP1, EBR, and EBNA will be expressed. You can illustrate this in your laboratory by using some immunohistochemical and some in situ hybridization stains. So again, to reiterate, for example, if you have a latency 3 infectious mononucleosis, you can use stains, EBR, LMP1, EBNA2, all of them will be expressed. Latency 2, for example, polymorphic PTLD, only EBR and LMP1 will be expressed. And latency 1, for example, plasmablastic lymphoma, where it is no longer dependent on the EBV-derived proliferation, this will be only positive for EBR. So now that we have the Virology 101 sesh out of the way, let's dive into the EBV, lymphoproliferative disorders. So these are a group of disorders that can range from B cells, T cells, NK, and NK cell derived with a wide spectrum of clinical pathological features. They range from indolent, self-limiting, and localized lesions all the way to aggressive lymphomas. You can divide broadly these disorders into two main groups. Those that are associated with immune deficiency, and I'm using here the old classification, and those that are without known diagnosed underlying immune deficiency. Because EBV is strongly related to immune deficiencies, we are going to concentrate on the first group today, and I'll touch upon two of categories from the other group without known immune deficiency disorders, and perhaps if we do a decent job today, maybe Saeed will invite us again for another session and we can discuss the other group in the future, inshallah. So, but if you want to read further about the other disorders, I would like to direct you to this article. You can go ahead and scan the QR code. Scan it. تعبانة فيه وكشخانة عليكم. This article is very nice. It discusses after the ICC classification, the review of non-immune deficiency related EBV disorders. So if you look at now the old WHO classification and the ICC, they divide the immune deficiency-related lymphoproliferative disorders into four main chapters: PTLD, HIV, primary immune deficiency, and immunogenic, and then the add-on is the immune senescence. So these are heterogeneous lesions, and even though they are heterogeneous, they have some commonalities. The commonalities being frequently involving the extranodal sites, aggressive histology, association with herpes virus. They can present with rapid clinical course, and they can pose difficulty in diagnosis. Even though they are heterogeneous, they present with a similar spectrum of morphological findings, which can range from reactive atypical lymphoproliferative disorder to a polymorphic lymphoid proliferation, and all the way to an overt lymphoma, which can be B cell, T and K cell, or classical Hodgkin lymphoma. Now, despite the overlapping morphological, immunophenotypic, and sometimes biological features, the ICC continues to divide the immune deficiency-related disorders into these main four categories, with the argument being the PTLD has a very significant management plan and course and needs to be remain separately. But it disregards that now with the introduction of new modalities, the list is growing and we can't keep on adding new chapters as new modalities causing immune deficiency emerge. So depending on and based on a workshop that was conducted in 2015, conducted by the Society of Hematopathology and European Association of Hematopathology, the WHO 5th edition has taken a nuanced approach to the classification. It has introduced a broader overarching framework with three-part diagnosis. So they suggest that you should diagnose these cases with a three-part system. The first being, give it the histological diagnosis that you see. It could be, for example, large B-cell lymphoma. It could be a follicular hyperplasia. The second part mentioned the association with the virus. Is it associated with EBV, HHV8, or negative to both of them? And the third part would be mention the clinical setting in which this disorder is occurring. So the idea for this being that this integrates the entire spectrum of the immune deficiency disorders. And now that we are being faced with and introduced with a lot of other modalities, such as CAR T cell therapy, immune modulation, PD-L1 therapy, or polychemotherapy, for example, solid tumors, and we don't know exactly how these disorders affect the immune system. So it's not only immune deficiency, we need to consider dysregulations that these new modalities are creating. So the new terminology by WHO is immune deficiency dysregulation associated lymphoproliferative disorders. So side to side, if you compare both classifications, you see the WHO 5th edition uses the histological finding as the main criteria for diagnosis, and the ICC uses the clinical setting for diagnosis. However, it has added the last EBV polymorphic lymphoproliferative disorder, acknowledging that some of cases with new immune dysregulations can present with these entities. Regardless to which classification you ascribe to, the bottom line is that I will be honing on throughout the whole lecture is all these clinical entities will present with similar morphological spectrum, ranging from reactive proliferation or atypical lymphoid proliferation to a sort of polymorphic lymphoid proliferation. It's not benign, it's not malignant, somewhere in between, and all the way to a lymphoma. So because post-transplant lymphoproliferative disorders were one of the first entities that were identified to be associated with EBV, and they form a very nice prototype for us to discuss the whole spectrum. We're going to discuss this the first and look at it in greater details. So PTLDs are a group of lymphoid or plasmacytoid proliferation that develop due to immune suppression secondary to or for recipients in solid organ, bone marrow, or stem cell transplant. Majority of them will be EBV positive. However, the later you go into the history of the disease, you might lose EBV. So King Faisal Hospital, you might know that it is one of the major transplant centers. Our transplant program is quite old, goes back to a couple of decades. And in 2023, we crossed the 1,000 mark for organ transplant. The program consists of liver, intestine, heart, lung, kidney, and pancreas transplants. And you might have heard in the news lately the first robotic heart transplant in the world, as well as now the liver robotic transplant. What this means is that we are continuously being faced with transplant-associated lymphoproliferative disorders, and this has enhanced our experience and understanding of the disease tremendously. So what are some of the risk factors to develop PTLD? The number one would be type of organ transplanted. Some organs have a higher risk than others depending on the severity of immunosuppression that the patient will have. So for example, heart and lung transplant patients have a higher risk of developing PTLDs. So related to it is the amount and the type of immune suppression, viral status. EBV negative recipients from an EBV positive donor will have a higher risk, age, and underlying immune status in general. Let's look at the clinical features and some criteria of the three morphological spectrums of the PTLDs. So if you're using, you can see the terminology for WHO and the terminology for ICC. The non-destructive or the hyperplasia diseases clinically present majority in children, and they will present with tonsil or adenoid masses and in in lymph nodes. The polymorphic lymphoproliferative disorders can be extranodal, short time after transplant, and can have an effacement of the nodal architecture. The lymphoma cases will be often late onset disease, and usually they can be nodal or extranodal. Now, treatment, your clinician will opt to use multiple modalities of therapies depending on what you tell them in your histological findings. For example, in the early or non-destructive or the hyperplastic lesions, your oncologist or clinician might try to reduce immunosuppression if possible, and close follow-up. In polymorphic lymphoproliferative disorders, reduction of immune suppression, again, if possible, and then maybe rituximab and close follow-up. The monomorphic PTLD now will be treated as any other lymphoma. Of course, immunosuppression will not be in the question at that stage, and you might get away with rituximab only, rituximab with chemotherapy. Histologically, the hyperplastic or non-destructive PTLDs have a normal architecture, and the three histological patterns that you might see is a reactive follicular hyperplasia. You can see a plasmacytosis or plasmacytic proliferation, or an infectious mononucleosis-like reaction, and you will see few EBV positive cells. The polymorphic lymphoproliferative disorder will have an altered architecture. It might be effaced, necrosis is common, and many EBV positive cells. Monomorphic PTLD, you'll have effaced architecture, you'll have a full-blown lymphoma, and you use the criteria for diagnosis of your B, T, and K cell lymphomas. EBV can be positive or negative. And then the clonality for the hyperplastics are polyclonal, and then the others can be monoclonal. So let's share some examples from our files of these entities. Hyperplasia arising in immune deficiency disorder. So this is if you're using the WHO. If you're using the ICC, you'll call it non-destructive PTLD. And the morphology can range from follicular hyperplasia to plasma cell hyperplasia or proliferation to infectious mononucleosis. This is a patient who had heart transplant 2 years ago, and then he developed snoring and upper airway obstruction. The tonsillectomy was performed. You can see follicular hyperplasia. So if you look at it without history, you will realize this is just a follicular run-of-the-mill follicular hyperplasia of a lymph node. And if you have the index of suspicion, you perform an EBV stain and it'll show you clusters of EBV. Without EBV, you cannot call this kind of disease as a follicular hyperplasia related to post-transplant, and EBV would be a crucial stain. Now, keep in mind, just scattered EBV is not criteria to call it or bump it to a PTLD, because most of us will have EBV positive cells. You need a substantial amount of EBV, like shown in the two examples here, to call it a non-destructive or follicular hyperplasia, EBV positive disease in a setting of, let's say, renal transplant. The other morphology would be plasma cell proliferation, another one of our patients showing you plasma cell proliferation. Kappa lambda show polyclonal. There is no clonality if you're lucky to send for flow or molecular. So this is another non-destructive type. And the third one is infectious mononucleosis. So here you'll have a spectrum of maturation. You have large cells, small cells, some immunoblasts. You can even have Reed-Sternberg-like cells, and you will have EBER positive and LMP1 positive, such as this boy after post-bone marrow transplant. Let's move on to polymorphic lymphoproliferative disorders. If you're using the WHO, so you can use it in any setting of IDD, or a polymorphic PTLD if you're using the ICC classification. These are a group of heterogeneous lesions. You will have a full spectrum of morphological findings. You'll have small cells, large cells, immunoblasts, RS-like cells. So you have a whole spectrum of maturation of lymphoid lymphoid cells, and it can be monoclonal, oligoclonal, and it's often treated with immunotherapy alone or immunotherapy with chemotherapy. So this is an example of a patient, 80-year-old boy after a renal transplant, 3 years, so short term, and presented with seizures and found to have brain lesions. So this is a biopsy from the brain showing you effaced architecture, necrosis is quite common. And then the slide on your right shows a spectrum of maturation. You have small cells, large cells, immunoblasts. So there is no monotonous one population of proliferation, and EBV is strongly positive. Let's move on to lymphomas arising in a setting of immune deficiency and disorders, or if you're using the ICC in the setting of PTLD, it will be a monomorphic PTLD. So as we mentioned, these lesions should fill the criteria of your regular diagnostic workup for lymphomas. You can classify them according to your diagnostic criteria for Burkitt lymphoma, B-cell lymphoma, plasmablastic lymphoma, or T cells like, for example, peripheral T-cell lymphomas, classical Hodgkin lymphomas. They often occur late in the transplant, and they can be EBV positive and negative. The later you are in the transplant, the lesser chances of EBV being positive. So as I mentioned, you can have B-cell, your regular B-cell lymphomas, T-cell lymphomas, and classical Hodgkin lymphomas. We used to consider that most of these PTLDs monomorphic are aggressive lesions. However, now reports have emerged that you can have low-grade B-cell lymphomas in the setting of PTLD, but specifically marginal zone lymphomas. So one of the first reports was by the group of Swaldrow and his colleagues, where he reported 4 cases following solid organ transplant. They were mainly extranodal, subcutaneous. They had marked plasmacytic differentiation, so sort of like a polymorphic PTLD. However, they lacked necrosis, and they didn't have the latency 2 pattern of infection. This is an example of one of their patients where you see a monocytoid, plasmacytoid appearance of proliferation, EBER is positive, and kappa restricted, lambda negative. So one of the examples of extranodal marginal zone occurring secondary to PTLD. However, later on, more reports started emerging that this extranodal marginal zone EBV positive is not just associated with PTLD. It can be seen also with other immune deficiency disorders, for example, iatrogenic due to methotrexate in rheumatoid arthritis, or immune senescence, or immune deficiency. So they reported cases, for example, this one, you can see nodular proliferation, monocytoid appearance, and then again the same morphological findings of marginal zone lymphoma, but other than PTLD setting. So far, only marginal zone lymphoma is considered the low-grade B-cell lymphoma that you can call in a setting of immune deficiency. Apart from the marginal zone, all of the other lymphomas will be one of your run-of-the-mill aggressive lymphomas. This is an example of a patient post-renal transplant presented with an abdominal extranodal mass. You can see the needle core is infiltrated with sheets of these blastoid, high-grade looking cells intersecting the skeletal muscle, and CD20 positive, Ki67 is almost 99%, MYC positive, so this, and EBV positive. So this is one of the examples of a higher grade B-cell lymphomas in a transplant setting. This is another patient with a lung transplant history 10 years back. Lymph node biopsy showed sheets of large cells, CD3 positive. I'm not going through all the immunohistochemical markers that we did. This is not the intent of the lecture, showing you examples how you can see T-cell lymphomas in the setting of PTLD, and you can see EBER positive. And then this patient was a 9-year-old history of renal transplant, transplant and the diagnosis of classical Hodgkin lymphoma or monomorphic PTLD or classical Hodgkin lymphoma, EBV positive in a setting of transplant. The question arises is, are these monomorphic PTLDs similar to your immunocompetent lymphomas? This study emerged from the group from Spain, from Elias Campo, and they studied a group of pediatric monomorphic PTLDs. They had 31 cases ranging from diffuse large B-cell lymphoma and Burkitt lymphomas. They found that their diffuse large B-cell lymphoma monomorphic PTLDs had a low genomic complexity, and their Burkitt lymphoma cases in the setting of PTLD had a mutational profile similar to the immunocompetent patients. Interestingly, these diseases or these lymphomas were treated with a low-dose chemotherapy or a very mild regimen of rituximab with lowering of chemotherapy. So they might be a different basket of worms. Another editorial accompanying the paper mentioned that because some mutations can have a more aggressive course, such as the mutation notch gene and cell cycle gene, that we need to really look into molecular biomarkers required to filter the cases and triage them according to the risk factors. A paper from Mayo looked into the event-free survival and the overall survival for the different lymphomas in PTLD. And you can see here the T-cell lymphomas across the board had a very bad prognosis. Classical Hodgkin lymphomas did very well. And interestingly, look at the red and the green, the polymorphic and the monomorphic PTLDs didn't have much difference in prognosis, which indicates that we really might need to look into them and triage them further and see what's going on in the underlying biology. Management, we've already mentioned, but your oncologist and clinician will have to work on early detection. Screening is key, especially for patients younger than 1 year old, EBV negative, a transplant, and aggressive immune suppression. And you saw now that how the options might be reduction of immunosuppression alone or adding surgery, for example, the tonsillectomies and adenodectomies, or adding rituximab with chemotherapy. And I refer you to the NCCN guidelines where you can read at your leisure. This is the basic workup that is recommended when you are working up a case for PTLD. And then specifically, they discuss the management of post-transplant lymphoproliferative disorders, just emphasizing the ICC's point of view in keeping them as a separate entity. So you can see the non-destructive type, the polymorphic type, and the monomorphic types. A close condition that is related to the polymorphic PTLD, and Dr. Lina also shed some light on it and showed us some interesting cases, is the EBV positive mucocutaneous ulcers. So these are lesions that occur in patients with age-related or iatrogenic immune suppression, so in an immune senescence setting, or an iatrogenic due to some kind of chronic immunosuppressive therapy. They usually have indolent clinical course, so that's key, and they can have spontaneous regression. So the clinical findings and the clinical history is very important in these disorders. We're usually not very lucky to get the full thickness of the biopsy. If you are lucky, you'll see the cuffing of the lymphoid cells around the ulcer. They commonly occur in the gingival cavity or oral mucosa in an area that there was a prior ulcer. You can see them in the skin, and like Dr. Lina showed us, in the GI tract. They have a waxing and waning clinical course, and you have to have a single lesion. If you have this kind of lesion with lymph nodes, then this is no longer a consideration for EBV mucocutaneous ulcer. This is an example of an elderly lady who presented to us through our consult service with a gingival mass. You can see here the non-keratinizing squamous epithelium with the ulceration of the mucosa on top, and there is some kind of infiltrate in the submucosa. A closer view shows you that you have an infiltrate of mixture of large cells, basically, which have vesicular chromatin and a polymorphic lymphoid background. Polymorphic lymphoid background. The immunohistochemical stains is alarming if you see it without a context. This shows you CD20 positive was strongly highlighting the large cells, CD30 positive, and EBV positive. So if you look at it, you'll say, is this a B-cell lymphoma? Is this a EBV positive B-cell lymphoma? Is it a Hodgkin lymphoma with CD20 positive, or is it a gray zone lymphoma? But with the clinical setting, with the waxing and waning, with the isolated lesion in an elderly gingival mass, you can make the diagnosis of EBV mucocutaneous ulcer. Another example here, which I wanted to show you that it can present with really mummified RS-like cells. The pitfall would be Hodgkin lymphoma. This case showed strong CD30 positive. But another tip would be looking at your EBV stain. The EBER stain will not highlight only the Reed-Sternberg-like cells, but if you have large cells and then in the background smaller cells also staining for EBER, then this is most likely not an Hodgkin lymphoma, and this you consider EBV mucocutaneous ulcers. Let's shift gears now. From now on, it'll be smooth sailing. Now you're primed and you know about the spectrum of diseases. We will just hit some important points. The lymphoproliferative disorders associated with HIV can present with a broad age range, usually involve lymph nodes, generalized lymphadenopathy, and typically occurs later after the infection. Again, you can have the spectrum ranging from hyperplasia to polymorphic to monomorphic lymphoid proliferation. An example of a patient who was known HIV presented with lymphadenopathy and showed follicular hyperplasia, nice, prominent, juicy follicles, and some of them are really irregular. We call them serpentine. The CD21 highlights the dumbbell appearance of the follicles. So this is an example of follicular hyperplasia and follicular lysis in HIV setting. The lymphomas now in HIV can be aggressive. They can present with bulky disease, elevated LDH, CNS lymphoma is common. However, it has decreased with heart therapy. If you compare them, the Burkitt lymphomas are one of the few lymphomas in HIV setting that the patient will not be diagnosed with AIDS and can be the presenting symptom. The plasmablastic lymphoma, CNS lymphoma, and primary effusion lymphomas will be extranodal. The CD4 count will be low, associated with EBV, and the PEL will be positive for HHV8. This is an example of a prisoner who presented with abdominal pain and inguinal lymphadenopathy. Biopsy showed this partially effaced nodal architecture with some residual lymphoid follicles and then some atypical follicular proliferation at the side. A portion of the lymph node showed spindle cell proliferation, which was positive for HHV8. So the lymph node had element of Kaposi sarcoma, and then we went back to look at it with to analyze the other lymphoid or follicular proliferation. Over here, you can see the CD21 highlighting follicular pattern. BCL2 is negative, but one of the areas showed a little bit of partial effacement with enlarged pattern. The proliferation consisted of monotonous, medium-sized, blasty-looking cells with tingible body macrophages, CD20 positive, Ki67 high, and EBV positive. So this was a Burkitt lymphoma with the spectrum of some follicular hyperplasia and Kaposi sarcoma. Our mentors always told us that in a background of HIV, always look for 2 diseases, don't stop at one. So look at your lymph node very carefully. A kind of advancement in the EBV setting is the association with advancement in the Burkitt lymphoma is the association with EBV. In the old WHO, we used to classify them or subtype them according to epidemiology into sporadic immune deficiency and endemic forms. However, now with the, we know that MYC is one of the most important genetic markers that you see in Burkitt lymphoma. However, the MYC translocation is not pathognomic, it's not specific, and it's not enough to drive oncogenesis. Along with the MYC, you can see ID3, TCF3. So these are other mutations that you see in EBV positive Burkitt lymphoma. However, now we know that EBV negative Burkitt lymphomas are different biologically. They have higher levels of somatic hypermutation, and it was found that they do not carry this TCF3 or ID3 mutations. In fact, it's quite exclusive for EBV positive cases. So depending on this now, the WHO recommends that you divide or you subtype the Burkitt lymphoma according to biological subtypes into EBV positive and EBV negative cases because it might carry implication to therapy.
5 minutes.
The second entity for plasmablastic lymphoma under HIV is plasmablastic lymphoma. These occur in the oral cavity associated with HIV or immune deficiency or in a transplant setting. Now we have reports that they can be secondary to transformation of follicular lymphoma or CLL, SLL, and some reports even secondary to CAR T cell therapy. I'll show you the examples. This is a patient, again, who was referred as a renal, as a perianal mass. You can see sheets of atypical cells with blasty chromatin and monocytoid / immunoblast-like morphology. The CD45, 20 B cell markers were negative. Plasma cell markers were positive. EBV and MUM1 positive, MYC positive. So this is a typical example of plasmablastic lymphoma. We recommended screening for HIV, and HIV was positive. We move on to inborn errors of immunity. This is the new terminology instead of primary immune deficiency. These are rare, mostly in children. There's more than 100 types, but 18 types are strongly related to lymphoproliferative disorders. Some of the common disorders are seen here, and you can see that most of them are associated with EBV. They commonly present with B cell lymphomas. Some of them can present with T cell lymphomas. I'll share some examples of 2 diseases. So first up is ALPS disorder. So autoimmune lymphoproliferative syndrome, where you can have the benign finding of CD4 negative, CD8 negative expansion of T cells in the lymph node, or the patient might present with follicular hyperplasia and PTGC, so progressive transformation of the germinal center with this big nodule in the center. You can stain it with IgD. To highlight the PTGC. Lymphomas are rare, 3 to 10%, can present with B, T, or classical Hodgkin lymphoma. This is an example of one of our patients with ALPS who presented with a T cell lymphoma, and EBV was positive. The second most common immune deficiency is common variable immune deficiency. They can have a variety of clinical features. They can be totally asymptomatic, or present with autoimmune disease, granulomatous inflammation, or enteropathy, and all the way to lymphoid malignancies. This is a patient who's actually a physician who was diagnosed initially as ankylosing spondylitis, presented with aphthous ulcer and joint pain. Later on, developed pulmonary nodules, which were granulomatous, AFP negative. She went on to develop pericarditis and then even enteropathy findings and colitis. At the end, she was diagnosed with a very rare variant of common variable immune deficiency. I share with you our index case, Layan, who was a 3-year-old girl presented with generalized lymphadenopathy. Lymph node showed granulomatous inflammation. AFP was studied, the lymph node was studied with bacteria. So this was kind of like a BCGitis. Later on, lymph node biopsy showed a polymorphic lymphoid proliferation with a spectrum of disease. So we couldn't call it lymphoma, but it showed some large B cells, some large T cells, CD30 positive in the immunoblast. It wasn't Hodgkin, EBV was positive. So we raised the concern for lymphoproliferative disorder. Later on, she developed massive lymphadenopathy. This lymph node showed diffuse sheets of large cells now, CD20 positive, Ki67 positive, EBV positive, so large B-cell lymphoma. Iatrogenic is lymphomas that occur, or lymphoproliferative disorder secondary to prolonged therapy for methotrexate, for example, in rheumatoid arthritis, and the morphology will be the same. The last entities that we will discuss is the EBV, lymphoproliferative disorder with no known immune deficiency. So the first one will be EBV positive diffuse large B-cell lymphomas, and they usually are described in the elderly. The new classification has aborted the suffix of in the elderly. It can occur due to immune senescence, it's aggressive, and will present as a morphologically common to present as a T-cell rich B-cell lymphoma. So this is one of our patients, 85-year-old with EBV positive. Now there are reports that younger age groups can also present with EBV positive large B-cell lymphomas, no known history of EBV, and they have a better prognosis than the elderly age group. This is one of our patients, which was a child who presented with no known history of immune deficiency, and you can see the sheets of large cells, CD20 positive, EBV positive. You have to raise the concern that this might be secondary to immune deficiency, but now we know that they can be without underlying disease. The last entity is lymphomatoid granulomatosis. So this was first described by Libo, and it occurs in the lung. The main findings here, the main tips takeaway is you have to have lung involvement. First, we used to describe them in the brain or skin without lung involvement. So it has 100% occurrence in the lung. You have angiocentric pattern, angiodestructive pattern. This is a patient who presented with seizures and then again with lung lesions, documented to have angiocentric, angiodestructive disease. And CD20 was positive, EBV was strongly positive. So this is grade 3 lymphomatoid granulomatosis. And you can grade the lymphomatoid granulomatosis according to the large cells and the EBV positive cells per high power field. So as we conclude, we have seen that the EBV positive lymphoproliferative disorders consist of multiple clinical entities, but you have to keep in mind that the list is growing and you have to consider other new modalities that can lead to immune deficiency. And the morphological spectrum can range from a reactive atypical to all the way to a polymorphic lymphoid proliferation and to a monomorphic BT or a classical Hodgkin lymphoma. Now, even though they are heterogeneous lesions, the EBV plays a major role. We have seen that the chemokines and LMP1 play a major role in the pathogenesis and the oncogenesis of the virus. Accurate diagnosis needs morphological, pathological, and clinical genetic findings, and it might be time for a reappraisal to look into the polymorphic versus monomorphic PTLDs. I leave you with a final thought that the EBV-related lymphoproliferative disorders are a group of hitherto maladies. Our immune system is a complex and mysterious creation. So take care of it, everybody. Thank you.